listening to the Medic Materials Podcast, hosted by Mike Turek, Emily Yates, Kelsey Coons, and Gerard Cuomo. All are current EMS providers and educators with a combined 30 years experience. Each month, we discuss EMS news, medical science, and review actual EMS calls, bringing many educational opportunities to the listener. Portions of the calls have been altered to protect the privacy and identity of all involved.
Hello and welcome, everybody. And I'm going to pause for just a second so I can cough here because my pacemaker is going off for the first time during the show.
Oh, great. I just did a cardiac arrest. I don't want to do another one tonight.
Don't worry, guys. You get pretty used to it, and you just start to ignore it eventually.
That's the first time this has ever happened where we're recording and it goes off and I have to cough.
The cough is getting more aggressive, I feel like.
I think that has something to do with me actually, having the vid. It's like part vid cough and part pacemaker cough.
You got the vid?
Mm.
Yeah, months ago.
Oh, you had the vid.
I had the vid. I don't have.
Right.
I had.
Right.
Yes.
Gerard, you've been exposed.
Oh,
Yeah.
That's it. I'm done. I'm done for.
But yeah, for those that, again, this is not something that I talk about, but just on a side bonus educational fact, when my pacemaker goes off, I actually cough because the one lead is so close to my esophagus that the electrical charge
Bronchospasm.
tickles my esophagus and makes me cough. So, I was waiting for this to happen, and there it goes. 36, 37 episodes, it finally did.
Well, if I ever have to get that, I'm going to see if they can put that lead somewhere more fun.
Yeah.
Woo! Yeah.
Gerard, you're on your own tonight working that code, too.
Yeah.
So, Gerard.
I was kind of doing the same thing today. No.
Hello. So we're here in the bunker with Gerard and our very famous clinical coordinator, Kelly, is joining us today.
Kelly,
and, I love her song.
Why? Because you're Kelly.
Of mine. Like it just ends so beautifully. And Kelsey, you're joining us from school, which is awesome. So I'm going to jump right in because this.
And Emily punked out.
Emily did punk out, but that's okay because this gives Kelly a great
Emily's
chance
in Florida,
to.
she's winning.
And Kelly just held up 2 middle fingers. So yeah. Okay, we got it. You understand?
Yep, it's fine. She'll miss this one, and that's completely fine. She's in Florida having fun, bitch, but it's okay. It's fine.
She's getting vacation that the rest of you people don't ever take.
That's true.
You're just jealous.
I mean, I would not be wrong saying I'm jealous.
What?
Take vacation, exactly.
I have no idea what that is.
Exactly.
But yeah, so let's jump right into, Kelsey, your rig check, and then we'll get started with this call review.
So today, guys, we're going to keep our rig check super short and sweet. We just want to shout out Ukraine and everything that the people there are going for. It's honestly been super cool, at least from my perspective. I don't know if anybody else's. I feel like we're basically seeing the war through a first-hand perspective, through social media, through the news. I think it's honestly going to be the most well-documented war. And it's amazing to see like the unity that the country has and the people that are coming out of the woodworks to be supportive and stand up for what they believe in. So shout out to everybody there and everybody even across the world who is still doing what they can at home to support them.
The first responders that are still there.
Working.
Doing what they do. So,
Yeah.
Yeah, keep fighting.
Keep it up. So getting right into it, this call is going to be piggybacked off of the April 1st conversation that we're scheduled to have. We're going to be talking a lot about cardiac and cardiac EKGs over the next, 2 episodes. So this one's going to be heavy into cardiac, as well as the next episode, April 1st, is going to be just a discussion episode, and we're really going to lay groundwork for EKGs and 12 leads. So your guys' system is a very suburban county with a significant call load. It's covered in part by a countywide BLS ambulance system that also staffs ALS fly cars. Each BLS county ambulance is staffed with 2 EMT basics, and each fly car is staffed with 2 paramedics. Your hospitals in the area, there are 2 within the immediate area, 1 local community hospital approximately 10 minutes away, and 1 larger community hospital that has extensive cardiac services, but really nothing else, is approximately 30 minutes away. So you guys are dispatched for...
where is this?
Can you repeat that again? I zoned out.
You're not allowed to zone out.
Do you know how hard it is to do this when I'm not looking at anything but like my pagan cow pictures?
Your pagan cows?
Pagan cows?
Yeah, I've got like 2 little wood pallets with a painted pig and a painted cow.
Oh, painted.
We both fucked that up.
I thought she took up like voodoo or something.
I thought she was saying pagan.
I was like, I thought I felt something sharp in my back earlier. Yeah,
okay.
Pagan cows, like we're sacrificing animals and shit now.
Seriously, is
Wow.
that how you're passing
No.
paramedic? You're
That is
sacrificing
apparently
cows?
how I need to get rid of the intern's curse, because my preceptor on Friday looked at me and went, I don't know how you white cloud an entire county.
Yeah.
But I did.
Yep. It's not just me. It's you, because I do calls when you're not there.
Maybe you should sacrifice a cow to Jobu.
That's Jobu likes chicken.
Jobu.
So do you want the system or just the hospitals, Kelsey?
I just want the first hospital. I heard about the cardiac hospital. I just missed the first one.
Okay, so the first hospital is a local community hospital that just does, basic stuff, nothing specialized, 10 minutes away from the scene.
Okay, thank you.
So you guys are dispatched a Delta Priority or a Priority 1 to a local residence for a 27-year-old female with complaints of severe shortness of breath and nausea. So with this, just right off the rip, are you guys thinking anything specific with this dispatch information? Severe
She's pregnant.
No, that's my first thought was maybe something to do with the pregnancy.
Yep. I mean, and this is, a fairly young patient, right? 27. We don't typically see a lot of younger people that have severe, ailments at that point. It doesn't mean that they don't, but we don't see it all that often. But these are some significant complaints. It's funny. Most of the time you hear severe shortness of breath coming out of the dispatch and you're like, okay, whatever. How bad really is it? Until I actually heard a couple weeks ago, one of the local dispatchers dispatch a call as extreme shortness of breath. And I had never heard of that before. And it ended up being a respiratory and cardiac arrest. And I was like, that's
pretty extreme.
Maybe I should take severe shortness of breath a little bit more seriously next time. But yeah, I agree with, pregnancy. Anything else that you guys are thinking right off the rip for this one? I'm like, asthmatic was one that...
Shortness of breath, the nausea. I mean, it could be an allergic reaction.
Right. Yep. I
like feel like
those.
The first thing that I'm thinking of is like, maybe it's just me, but I feel like people like my age, my sister's age, who are, around, 20s, don't really call 911. Like, not that you can't get 911 calls, but I feel like for it to be bad enough that they're calling 911, it's probably pretty serious. So I feel like people my age, either are complete babies about it and they call their mom, and then their mom convinces them to call 911, or, they just go to urgent care because that's all we know. I feel like most people don't think like, hey, I'm going to go pay for an ambulance at 20.
Well, right. I'm sure if somebody invented an app where you just swipe right to 911, you guys would do it.
Okay, this is not my fault, okay?
Can you have a situationship with an ambulance? Is that like...
I do not have a situationship with an ambulance.
I still don't even know. I still don't even understand the meaning of this.
I've outlived my shelf life. I can't do it anymore.
So for context, for our listeners, I was trying to explain the other day that, like, dating isn't really a thing nowadays. There's situationships and talking before you ever get to dating, and I broke people's minds. There's a TikTok about it.
Yep, you broke my mind, for sure. And, yeah, I'm still recovering, because I still don't even fucking understand it. But anyhow, so let's move on. So The BLS County ambulance arrives first to the scene. They find that she is seated in the passenger seat of her vehicle, which is currently parked in the driveway. Her boyfriend greets EMS and tells the EMTs that they are about to drive to the local hospital up the road. But when she walked to the...
Why didn't you?
Yeah, right? Well, you're going to find out.
She's in the car. Why are you still here? Why'd you call me?
Because
Go.
then she'd park on the side of the road with her flashers going,
Damn it.
hey, come get me as I'm around the corner to the ER. So they were about to drive to the local ER, but when she walked to the car with the boyfriend's help, her shortness of breath became worse, and she developed some chest pressure and then vomited once. Looking at her, she is in obvious distress, appears as though she is working to breathe, and is hugging a small car blanket on her chest. So is this presentation to you guys concerning? And if so, why?
Yes.
Yeah. I mean, this isn't something... Vomit is not something you can fake.
No.
You know, and then...
I mean, it is,
well,
but it's not.
To a certain extent. But
yes.
But the overall presentation, to me, is like shit.
Yeah. This is really bad. Yes.
Yeah, something's going on here.
And especially, with nausea is a response of the sympathetic taking over. And because it's literally shutting your gut down, and you become nauseous and you vomit. So if you're having, sympathetic overload, there is body in crisis mode, you know?
I mean, I have seen people work themselves, up with having like severe anxiety attacks that have gotten to, points like this too, where they've just worked themselves into a frenzy. So, I mean, right now, all that stuff is still on the table. So,
right. Kelsey, you were going to say something
I'm
about
going
concerning?
to take a quote from Emily on this one about your anxiety thing, is that the only way you can diagnose anxiety is to rule out everything else. And sometimes we can tell, but right now I haven't asked any questions. I don't even want that to be a thought in my brain, because then that's all I'm probably going to think. And I don't have the ability to rule out everything else. I'd be anxious if I was having a heart attack, if I was having a baby, if I was having any major illness and I had to call 911. Everybody we see is anxious because they picked up the phone and we're there now. I don't like to even think about anxiety until I can't think of anything else.
Well, and that's true, because a lot of people go into these calls, 27, it's anxiety. Right at the they haven't even set one foot in the truck yet, and it's already diagnosed anxiety. We're going to BLS it.
Because how many do we get that are like that?
Right.
Yeah.
And I fully agree. I think we need to flip the script in thinking, let's go through everything and then get to anxiety. That should not be our first thing. So the primary EMT begins their initial physical exam and finds her to be conscious, alert, and oriented ×4, speaking in 4 to 5 word sentences, and the car stinks heavily of thick cigarette smoke. Airway is open, patent, no fluid or debris is noted. Breathing is tachypnic and labored. Radial pulses are present, strong, rapid. The boyfriend tells the EMTs that she began to experience some minor shortness of breath about an hour ago with some minor chest tightness. This tightness then became a heavy pressure while walking to the car. She is still clutching the blanket and appears to be wincing in pain. When she's asked what hurts, she tells the EMTs that her chest feels so heavy that she can't move it. Her skin is pale, diaphoretic.
Can't fake that either.
You can't fake skin changes. So I would say none of these signs and symptoms are mostly a good thing.
No.
I mean, conscious, alert, and oriented, airway patent, great. The rest of it, other than pulses, is not so great. So are you guys leaning in any type of direction looking at these signs and symptoms? I know we've laid out a couple different paths, but knowing now with the chest tightness, with the diaphoretic skin, the paleness.
It's cardiac until proven otherwise.
Bingo, right? Kelsey, I'm going to direct this one right to you. With her being 27, is there... are we still thinking, let's do cardiac? And if so, what do these EMTs need to be doing next?
So we have the ALS fly car on the way. Yes, no?
Yes.
I'm assuming.
Yep.
Okay. So, I mean, at that point, there's nothing they can do about that. Like, they can't run a 12 lead. They can't check out what's going on with their heart. But I think, like, a really in-depth assessment. And, like, one of the first questions, I think, right off the bat after I get, like, her medical history is, like, what's your family history? I mean, you could have had a mom that had a heart attack at the ripe old age of 30.
Mm-hmm.
You know, maybe your sister has a pacemaker and she's 12. Maybe you just have a history. Maybe you have a congenital heart condition that for some reason you're just failing to, like, realize because you're under so much stress. And I think that although it's a good thing to think cardiac, I also, like, the first thing I want to do is listen to her lung sounds, because she could just be really, really tight because she's not moving air, and that's also causing chest pain.
Right.
So, like, I'm not going to rule out the heart, but I'm also going to focus in a little heavier on respiratory than I think I would if they were, like, 65 with 4 stents placed having chest pain.
I agree. You know, I think you have to presume it's cardiac until proven otherwise. But I agree. It could be a severe allergic reaction to something, and she's so tight that this happens, you know?
Like, I don't want to think one thing and miss something else that was right in front of me. So, like, I'm not going to throw cardiac out the window just because she's 27, because I hate the people that are like, oh, well, you're too young to be having a cardiac event. You're too young to be having chest pain.
Yeah,
Right.
Like,
young.
no, probably
Never too
not. But
young.
at the EMT level, I'm going to be able to assess her respiratory functions and what's going on with that way better than I'm going to be able to assess her cardiac function at this point.
Yeah,
Yep.
You're looking at a dude who did a 12 lead on a 12-year-old
Mm-hmm.
because she said chest pressure and tightness.
Yeah.
And I said,
All right.
lung sounds clear. Everything else was good. No history of asthma. No nothing like that. You're getting a 12 lead, kid.
Yep. Yeah.
Well,
Never too young.
And there was like a little abnormality. She had, I can't remember. This was a few years ago. I don't quite remember, but I remember I ran into her grandmother at, like, you know, a gas station or something one day when I was at work again, and, you know, weeks or months later, and she said, oh yeah, they found, like, she had, like, some kind of murmur and some other shit, and I was like, oh, okay,
That'll do it.
yeah, cool.
Yeah.
But yeah, 12 years old doing a 12 lead. I mean,
Right.
when I walked into the freaking hospital and said, yeah, I did a 12 lead, here's her EKG, and they were like, you did a 12-year-old?
Yeah.
Yeah, why not?
Yeah. And, you know, it's,
You know?
again, never too young. I made just a joke to my cardiologist the one time, the one that actually inserted the pacemaker. And we were in just a generalized meeting before the surgery, and I was like, yeah, you know, he's like, how you feeling? I'm like, you know, I'm so young. Like, I shouldn't have this issue yet. And he's like, you're not my youngest patient. And I was like, oh yeah? How old's your youngest patient? He's like 8. I was like, 8 with a pacemaker? Like,
Wow.
defect? He goes, nope. Like, completely normal, healthy kid until boom, they weren't.
Yeah.
And so yeah,
Well,
you're,
and if you
you're
think about
never
it,
too young.
like, I think. Oh,
Go
sorry.
ahead.
I think especially, like, for this, your best tool is going to be the questions you ask. Any recent history of, like, any sort of inflammation? Could it be a myocarditis? Could it be a pericarditis? Do you drink 12 energy drinks a day and now your heart is crapping out because of it can't handle it anymore? If you recently had any diet change, like, I think the best tools that these EMTs have right now is
their
basically
assessment.
firing every question that you could ever think at this poor girl while you can.
Another thing that might keep the respiratory on the table for me would have been the overwhelming stench of cigarette smoke.
Yeah. How much do
how
they
much do you
smoke?
smoke?
Yep.
Yeah.
Is it her? Is it the boyfriend?
Right.
You know, who knows? So as we move on, the secondary EMT moves to grab the stretcher while the primary EMT begins to assist her from the vehicle. As they move her to a standing position, she vomits one more time onto
Why
the
would
ground.
we do that?
Because people are stupid? I don't know. This is just the way it happened. What would Kelsey do?
Kelsey would have done an assessment before we moved her.
Okay, but now, what are EMTs taught?
I was not taught that.
You were taught something, but way back in EMT school a year ago, Kelsey, if you remember, you were taught if they're significantly a critical patient, you load and go. So a lot of EMTs will see her as a critical patient, and they will forego the let's slow down to find some stuff out. before we load and go. They'll just go, oh my God, she's really bad. We don't want her to die here. Let her die on the stretcher. So let's get moving.
I think at the very least, I would have at least gotten vitals before we went.
I agree.
Even as an EMT, I would have at least got some vitals.
I think there was time enough to slow down.
Well, it's A, B, even if by following your theory, it's A, B, C, D. Airway, breathing, circulation determine the priority of the patient. We did not do an A, B, or a C.
Yes, they did.
Yeah, they
Maybe
ABC.
Passively, but did we listen to lung sounds? No.
Yeah, no,
did we make sure chest was rising equally? No.
Isn't that what you said? They did the. I thought you said they did an assessment.
They did.
Okay.
They did an ABC. The only thing they did not do in the ABCs was lung sounds.
Oh, okay.
Which ultimately they do later, and they were clear.
But,
well.
No, I would have done vitals, and then I mean, basic EMT protocol with this presentation. I mean, yeah. If you're in a system where you have no paramedic and you're the EMT, I mean, I'm sorry, but yeah, you got to give aspirin.
Yeah. You know,
this is
first line.
This is screaming to you as a basic. I give this person some aspirin and ask them about nitro.
Yes. Yep.
You know, especially if their BP's through the roof.
Right. Yeah. So, as I said, they move her to a standing position. She vomits one more time onto the ground. She's then assisted to the stretcher and then placed inside the ambulance. The primary EMT, once inside the ambulance, begins to obtain a baseline set of vitals. Okay. Pulse ox probe is placed and shows a heart rate of 120. When palpated, it is still very strong and meets that rate around 120. Oxygen saturation is 90% on room air. The primary EMT then instructs their partner to place her on 12 liters per minute oxygen via non-rebreather because high flow fixes everybody. They do it. Blood pressure via the manual cuff returns as 188/98. Okay. Respiratory rate of 26 in labored and shallow with complaints of a 10/10 chest pressure. Now, they do go through a slew of questions at this point in time. She does smoke. She smokes about a pack a day. She is not pregnant to where she knows. She does not have any cardiac history. She doesn't take any meds. She doesn't have any allergies.
Is she on birth control or have a form of birth control?
Good one.
That is a really good question.
Especially if you smoke.
Yeah, exactly, right? I don't honestly know.
Because, like, the loaded question when you ask females, do you take any meds? Well, no, I don't take any pills. But there's so many different forms of birth control nowadays that you could still have the same effect because you could have hormonal birth control, which is what evidently is what causes the clotting issue, versus non-hormonal. And nobody thinks of it because, well, I don't take a pill every day.
Right. And, I mean, Kelsey, again, this is not something that I would know, but, you know, in all the transports that I could remember of people in childbearing age that would be taking some form of birth control, when you say, hey, are you on any meds? They're like, no, because birth control is a med,
I'm on birth control.
But they don't ever say it.
Yeah, it's like the old people. Oh, do you take, you have high blood pressure? No.
Right.
Because I take my high blood pressure meds. Yeah.
Exactly.
Right.
So.
And it's definitely becoming more frequent, I would say. Like out of even just like personal experiences, there are a lot of females that I know who take it because there's a lot of things that birth control does besides preventing babies. You know, a lot of people get on it for 1.5 million other reasons. Mm-hmm. And they just don't take like a hormonal version because something else works for them.
It was that one, Depakote, I think, is like the big one that they give out for,
I don't know,
regulating, bad menstrual cycles for, I think, is it Depakote?
Yeah, like some people take it because they get anemic, others take it because they'll get like ovarian cysts. Like there's a million reasons you can take it besides, not wanting to get pregnant.
Right.
And then, if you don't take the pill form, no, I'm not on any meds.
I mean, according to today's protocol, the easiest way is not to be in a situationship and just go back to our version of dating. True. I mean,
okay, well, I can't help you guys with this one. I don't think you should be telling your patients to get out of their situationships.
There's always the old caveman, you just club them.
So the primary EMT then asks their partner to find out how long until the paramedic fly car arrives on the scene. County tells them approximately 2 minutes. They go ahead and they do administer 324 milligrams of 81 milligram aspirin
Good for them.
per their cardiac protocol. So awesome sauce.
Yep.
And this agency is also equipped and trained for BLS 12 lead application.
Oh.
So they can apply it, they can run it, but they cannot interpret,
Right.
is from my understanding. So the 2 EMTs turn on their cardiac monitor and place her on a 4 lead and then a 12 lead EKG. They obtain a printout, but again, not equipped to read the rhythm strips. So are you feeling like everything that they're doing so far is appropriate other than the stuff that we had mentioned? Just a quick, I think they're on the right path.
The only thing I would have done different is, like I said, before moving, I would have got my vitals.
Which I agree with because, again, and I didn't say it before, if you move them and then you recheck a set of vitals, you could see a change, right? Did they go hypertensive? Did they go hypotensive because you moved them?
Right.
What changed? So, yeah, I definitely would have done at least 2 there.
Yeah.
1 before, 1 post move. Kelsey, are you finding that these guys are doing well in their job right now?
Yeah, I mean, I think the only other thing I would have probably asked would be like any sort of family history, just because anything cardiac is always known to have some sort of genetic component to it.
And that is something that these guys did not obtain.
But I don't think like that's the biggest red flag in the world. Like they could be doing so much worse.
And granted, I've done that in that I go, do you have a history? I don't go, well, does your grandpa, does your dad, does your parent, like, I don't do that.
How much time has passed from the time they got on scene to the time this 12 lead's getting done?
If memory serves me, I didn't write it down, 7 to 9 minutes.
Okay, no, that's good.
Somewhere within the 10-minute
That's fine.
mark.
That's what I was going to say.
Yeah. It wasn't.
If we're outside the 10 minutes, then I would have done the 12 lead with her sitting in the car.
Yeah. Which, again, you could see changes if they were moved, right?
Yep.
So at this point, the paramedic fly car arrives on scene. The primary, and remember, there's 2 paramedics in this.
Where is this? I got to go there.
Seriously, right?
Right?
I was like, this system's
2
kind
EMTs
of
and
neat.
2 paramedics? Shit, I don't have to do a damn thing.
Seriously, right?
Jesus.
In a county system, so that's
Right.
county pay.
Oh,
like,
damn.
Oh, yeah!
so
Wow.
the fly car arrives, and the primary medic gathers their ALS and airway bag, and then enters the ambulance. Because they're just going to use the cardiac monitor that's in there.
Right.
They're given a full report on what the EMTs have found out and done up until this point. The medic performs their own initial physical exam, building off of what they were already told, finding there's no jugular vein distension. She denied any chest pain, only complaints of severe pressure with no reports of radiation of that pressure. She also denied any abdominal...
Where?
What?
Sorry. Where is the pressure? Like central chest, right chest, left chest, all over the chest?
It is completely left to right sided across the chest.
Okay, like a tight band almost.
Yes.
Okay.
To the point where she's saying that there's so much pressure she cannot expand the chest. So she also denies any abdominal or back pain. And then the medic is given the cardiac rhythms, which are read, and shows the 4 lead shows a sinus tach with very irregular and short looking complexes. Now, if I told you that, Kels, what would you think of? If you have a sinus...
Say that one more time. Sinus rhythm.
A sinus tach with irregular and short looking complexes. What would you think of if you saw a short, tiny little complex?
Like a short little QRS complex?
Mm-hmm. Very short. Like,
This is so hard to do without something in front of me. Hold on.
I know. That's why we're putting you right to the test.
Hold on. Give me a second to picture it in my brain.
1 second. Dum 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 dum.
So you would be having decreased ventricular repolarization.
Okay.
And if they're irregular, it means your ventricles aren't repolarizing the same.
Okay. I like where this is going. Anything other than repolarization factors?
What do your P waves look like? Fine?
They're fine. So let me just throw out a hint to everybody. Could it be with repolarization? Because I definitely like the repolarization thought process, but could it just be that there is low voltage in your lines? So you're not getting a big grand picture. You're only getting a minute low picture because of low voltage. So then all you do is then turn up your monitor to be able to see a bigger complex. So it could be as something as low voltage. Maybe you have to change your leads. Maybe you have to change the position. Or it could be low voltage because of what's going on inside the heart. There's lots of different things that could be causing a low voltage or repolarization issues. I agree with both. So you have this sinus tach with these irregular, short-looking QRS complexes in the 4-lead. The 12-lead is red, and it too shows a sinus tach with these short complexes. However, there's a counted 4 millimeter elevation in 2-3 AVF with 2 millimeter elevations in V5, V6 with a 2 to 3 millimeter depression in V3 and AVL. So if I said that to you, Kelsey, what are you thinking? You have 4 millimeter elevation, so 4 small boxes, almost 1 big box on the 12 lead in 2-3 AVF. So that's elevations in what?
Inferior wall.
Okay. And then 2 millimeter elevations in V5 and V6.
So possibly lateral involvement.
Okay. And then 2 to 3 millimeter depressions in V3 and AVL.
Probably, well, AVL would just be some probably less developed changes to your lateral wall. V3 could just be reciprocal changes, or it could also be like the beginning of some septal involvement. Septal?
Oh, yeah!
Yeah.
Gotta give her.
Yeah.
Awesome sauce.
But I have a question that
No,
you
you
might
don't.
not know the answer to.
Why do you do this? You're supposed
Well,
to make me
because
look
it's a
smart
question
and ask
about
questions I know the answers to.
Isn't a sign of pericarditis is short QRS complexes?
Yep.
And it can also lead, so she could be having a STEMI, very possible, but she could also be having a bout of pericarditis because it can lead to changes in elevations.
What kind of elevations?
Usually I feel like they're more global, though.
Exactly. They're not very specific to a contiguous lead. It's more they're everywhere.
Okay.
So
Because I feel like you have a lot of elevations. You're just missing. So, I mean, she could just be having a massive STEMI, but.
I agree. I 100% agree. And it's really good that you're thinking other lines. Like, we're not just going, yep, it's a STEMI. It's confirmed, right? There could be other causes for all of these elevations and depressions. So, Kelsey, what are your first next steps for this patient? Knowing what you just said on the 12 lead, what is your immediate next step as this paramedic? As you are the queen
at
paramedic.
This point, I want
intern.
another set of vital signs. I've got 2 paramedics. Start a line, give some nitro. Because at this point, whether it's a STEMI or if it's pericarditis, her heart is working too hard.
I like it. So,
I mean, at this point, I'm following ACLS until I can't. Like.
Well, exactly. And that's really all you can do, right? You've hit your algorithm and now you're going to follow it. So in this case, one medic actually steps out and goes back to the fly car. They don't utilize the second medic on the scene. They kind of just go, yep, we're going to start going priority 1 to the cardiac facility that's 30 minutes away. So the medic that does stay with the crew does start a successful IV line, 18 gauge to the right forearm. Awesome. They hang 1,000 normal saline bag, start an infusion, but nothing significant. As it was reported, only about 100 to 150 mLs was infused by the end of the transport. And the transport, was 30 minutes. So that's really nothing. Remember that aspirin was already given. So aspirin was skipped by the paramedic and they went right to the nitro spray. So 0.4 milligrams sublingual spray. And then oxygen sats were now 100% on the non-rebreather. So the medic tells the EMT in the back, hey, let's switch that out. We're going to go from a non-rebreather to a nasal cannula, and we're going to go to 2 liters and see where her sats go,
Right.
which I think is good, right? So this is where I have to take a sidebar, okay? So at the time of this call, and this is something that we're going to talk about, I think, a lot in the finishing of this call.
Okay.
Because we're kind of spoiled with it in our area. I don't know if there's I'm sure there are other areas of the U.S. where they don't have this capability, or maybe it's impeded by where they are. But at the time that this call happened, the agency did not have the technology and the ability to transmit EKGs to the ERs. So the only way to tell the hospital of an incoming STEMI was to actually call the hospital and be like, hey, fuckers, we're coming in with a STEMI.
Right.
Not really an overall bad thing. I mean, we still do it today. We transmit, and then we call, and we say, hey, go get your printer. I just sent you something. It looks like a STEMI. I'm calling it a STEMI. What do you think? And then the whole STEMI activation is,
Right.
is followed through on. So just kind of keep that in the back of your head here. So the medic attempts to call the hospital via cell phone and notify them of a STEMI alert. But the phone doesn't go through. It just keeps, it connects, and it rings, and it rings, and then no one answers. So the paramedic hangs up, tries again. It rings, no one answers. Numbers checked, paramedic calls again, rings, no one answers. So they just stop at that point. They tried 3 times. Maybe they'll try again. But at this point, is that problematic? Like, is there anything specific that you guys would be willing to try in a situation, or really does it not matter in the long run?
It does matter, because
I mean,
you have to activate the team.
Right.
You have to be ready to go when you come in.
And that is
but
something that...
also, as much as it sucks, if it's a completely cardiac capable facility, you might delay care for 10 minutes, but it's not like it's the end of the world and your patient's crashing in front of you and you can't do anything about it.
But at the same point, it depends on what kind of cardiac center it is. Now, I didn't get this, so maybe that's a issue with me preparing. I didn't ask, is this a 24/7 PCI center where they have the team ready there all the time? Is this one where they have to call the team in and they can live 30 minutes away, and now it's not going to be 10 minutes by the time you get there. It's going to be 30 or 40, maybe 45 by the time they're actually doing a piece, like an actual cath.
Or maybe they've already got their hands full with other things and need to start reallocating resources.
Right. I mean, it's definitely something that needs to be said early. You can't just, I don't think you can wing this one and be like, oh, well, I hope.
Right. I tried, didn't work. Here you go.
Right. Doug.
But you could also have, it doesn't take much for the driver to sit there and keep pushing buttons on the radio.
Well, and that's it.
You also have a second EMT. Like, you have the hands to sit there and just keep trying.
Again, this is the conversation. I don't think there was the ability to just not try.
Right.
I think they did have the ability to actually try in this manner. So, as of right now, they stopped trying.
Okay.
Vital signs are retaken. They go back to patient care. Blood pressure's taken via the now auto NIBP cuff, and it spits out 177/91. Heart rate is still 111. A sinus tach on the monitor. Respiratory rate 26 and still shallow. SpO2 is 99% on the 2 liters nasal cannula, and her pain still remains a 10 on 10 with no relief thus far. So another 0.4 milligram nitrous spray is given, along with now 5 milligrams morphine IV for pain control. She's becoming paler in color, telling the medic that there is now pain and pressure in her chest. She is sewing. I'll hit the buzzer on that one. she is
So she took out her
showing
knitting needles and decided, hey, this is a great time to get back at that sweater I was doing.
Right. Well, she's becoming paler, so I'm sure she's becoming colder. She might need a sweater. So she is showing increasing anxiety due to now pain and pressure.
Yeah.
Right? Beginning to now move around the stretcher. She's getting that anxious, not good movement.
Yeah.
With this change, the medic establishes radio contact with the hospital instead of going cell phone route.
We just thought of that.
Yep, just thought of that.
Oh, okay.
And informs them.
You could have range issues.
You could.
Remember, your radios are line of sight. If you're in a hilly
I
area,
just
you
had
ain't talking
assumed
to
that
nobody.
it wasn't working.
Don't assume. Don't assume. Omaha is still good. Everything's still good in this. So they contact the hospital via radio and inform them that they could not get through via the phone to med control. They have an active STEMI alert and for the hospital to be prepared in approximately 20 to 25 minutes. So fast forwarding a little bit here, nitro spray is given every 5 minutes for the remainder of transport. Ultimately, no relief in pain, and blood pressure drops a few points here and there, and then just increases to the same range, anywhere ranging between 170 and 190 systolic. The medic continued to try and reach the hospital via phone with no success, just to be able to speak to that doctor. About 10 minutes out from the hospital, another dose of 5 milligrams morphine was given for increasing pain. She is now...
So I have a question.
Yes. I should have a yes thing on here.
Do we have repeat EKGs?
I'm sure we do. I just didn't ask for them.
So insignificant enough that, it wasn't mentioned.
For what?
There was no massive elevation changes, massive depression changes.
I would assume
we just stayed constant for 30 minutes.
I would assume so. However, again, show prep, poor me. You can buzz me, call me names all you want. It's okay. I did not specifically ask if there was another EKG. With her presentation, I would have to assume that there are higher elevations. Maybe those depressions moved into elevations just on presentation alone.
Yeah, now she's starting to feel the pain, so it's progressing.
Right.
Yeah.
That's just a buzz on my part for not asking. So,
okay.
Audience, I apologize. So now she was appearing pale, then she was appearing paler, and now she's starting to appear very ashen in color.
Oh, boy.
Right? Reports that the chest pain and the pressure are so bad that she now cannot expand her chest to breathe. Ventilations are now becoming more and more shallow. Monitor is now showing the sinus tach, but now with frequent PVCs.
Oh, boy.
And you're still about, at this point, 7 minutes away from the ER. Right? Yeah. Moving to 5 minutes from the ER, she looks at the medic and visibly looks like death. You and I have seen this look before, Gerard.
Yeah.
This is the look right before someone rolls their eyes backwards on you, and next thing you know, they're unresponsive, and you're like, fuck. Right?
Yeah.
She tells the medic she's not going to make it to the ER. Now, those are words that we all take for granted and we make fun of them, but patients actually say that shit.
Yeah.
And you have to believe it, right? And
if it's the drunk college student or whatever,
right?
Yeah, okay, you're not going to make it, whatever,
right?
But this presentation,
no,
you tell me that,
I believe you.
Yeah, you know what's coming more better than I can tell you.
Right, yeah. You can feel all of that brewing. You know. So the medic clearly looks at her and, reassures her they are so close. She can make it. Just keep pushing. Just keep going. But
I feel like he was just telling her to make it through labor.
Sometimes.
I mean,
that's
what else are you going to do? Don't die on me, like in the movies. Like, shake her a little bit so, you know.
Slap her.
You slap her around a little bit.
Control yourself.
But I will give I will give some significant props to this paramedic, because this medic was smart enough to realize the situation and get prepared by bringing out the defib pads.
Oh,
now
okay.
they didn't hook her up to them, but it was like, all right, we're gonna use
slap.
these. We're gonna open them up a little bit. We're gonna slide them behind her head, and we're gonna be prepared. They're just there. So, I've had this, these conversations with these patients. Gerard, I know you have had these conversations, and they are very unsettling. Like, they're not fun to have. And for those that have never dealt with this sort of like deathbed warning, how do you really go about it in a calming manner? Because you don't want to exaggerate, you don't want to lie, you don't want to make them peak in anxiety. They know that this is a bad situation.
Yeah, and I mean, there's no cookie cutter answer for that, because it depends on the situation.
Right.
And
It's almost like our death conversation we had last month.
You have to adapt to whatever you think is, not even what you think, just what you feel. I mean, sometimes it's just, sometimes, it's be calm, be reassuring, or whatever. Other times, you might have somebody that, you might need to get a little more fight in them,
Right.
And you got to, piss them off a little bit, get them angry. Hey, don't effing quit.
Yeah. Is that a fun scratch, Rubble? Yeah. My dog is scratching himself at my feet.
I can hear him jingling.
Yeah.
Well, Kelly's the one who invited him down.
Yeah. I mean, he's such a nice show dog.
I know.
You got to keep doing that? He's like, yep. I'm getting this scratch.
As long as he makes Kelly happy, that's all I care about.
That's true. We haven't tapped into cap yet.
What?
Damn
really?
it, wrong
you can't
one.
even hit the right fucking button anymore. Jesus Christ.
I'll double that one.
Wow. Holy
shit. Sorry. But yeah, so what was that?
This is why the two of you cannot be left alone.
This is also very, very true. Well, we're not alone. We have our brilliant clinical coordinator, Kelly, here.
Yes.
But so moving right along,
she just gave you that look, man.
Well, she's scary.
Such disappointment.
She's got to take over for Emily. She's the EMT badass today.
Thank God this is not TV, because that
You got a badass over here.
Oh, look at that.
Slid that one right in.
Nice. All right.
That's going to be Emily's.
Yeah.
Hey, we have Emily here.
Yeah.
We got a badass.
Wow. I like it.
Yep. So the medic administers the 7th nitro spray at this point, just as the ambulance is arriving at the hospital ER.
So I have a question.
Oh my God, she's so needy tonight.
Right?
This one you guys are gonna know.
Mm-hmm.
If by the 7th nitro it's not working, is there a chance that any more nitro is going to work?
Yeah.
You never know.
And
Like, I'm not saying you stop, but is it a really big red flag when you're 7 nitros deep and nothing is happening?
maybe it's the nitro that's kept it at bay.
Oh.
Okay, fair.
I mean, yes. Typically thinking, okay, I've given this for 30 minutes and no changes are happening and she's getting worse. But Gerard's right. Maybe those 7 have kept her from getting worse 10, 15 minutes ago. Right? Keep going. So they arrive at the hospital, and the EMT begins to move her out of the ambulance. And the medic's still sitting, behind.
Yeah, making sure the EMT lifts all by himself. Right?
Exactly. Like a good paramagician would do,
I'm just
right?
gonna sit here.
I'm just
You
going to
lift him
sit
out,
here.
Then I'll come out. Yeah.
Exactly,
Okay.
right? Got to make sure that hook,
Yes.
actually
that hook.
catches.
Yeah.
And then I'll lean over and unhook the hook. So, as the EMT begins to move her out of the ambulance, the medic notices a rhythm change from a sinus tach with frequent PVCs
Normal
to
sinus. Normal sinus.
No.
Defib.
Fuck.
To a ventricular tachycardia.
Fuck.
No. We're completely fucked. We're completely fucked.
Yes, we are.
Yes, we are, guys.
And they give her
Hey,
a good old precordial thump.
Wait a minute.
Whack.
No shit. She just brought out the pericardial thump.
Wow.
Like
What? Hey, I just realized something. We're not completely fucked. The hospital's completely fucked.
So that's so you literally just led into my next question.
Laugh ever.
But honestly, like I want to build off of this because I couldn't tell you. I would love to have a poll here. Maybe I'll put it up on Facebook.
I'm not stripping, dude.
No, I don't want to see
that kind of poll.
That kind of poll.
Oh, okay.
I'll put it up on Facebook because I actually am kind
Well,
of.
I mean, I could use the money.
Inflation, gas prices. We all need, second jobs.
Yeah, let's go, Brandon.
But realistically, there's two camps here.
Yeah.
Do we fix this now, or is it the hospital's problem? Right?
Ooh, that's a good one.
Kelsey,
Shocker.
paramedic
and walk her
intern,
in.
what are you gonna do? Shocker.
I mean, at this point, shocker, start CPR, and walk in. What are you, 3 feet from the door?
3 feet from the door.
But what I'm saying is, if you just start CPR and wheel her in, you just wasted that minute prime shock time.
Do we still have a pulse?
Because the hospital's going to take 7 years to do it. So shocker, start CPR. You can't do anything for another 2 minutes anyways. So walk her in.
See, did you hear Gerardo? He just asked a very, very good question. Now, granted, it doesn't much matter. I mean, it does, depending on CPR or no CPR. But does she have a pulse?
Yeah.
Right?
That's valid.
VTAC.
I forgot that we were in VTAC.
Right? So the medic actually sees this, goes, well, now we're completely fucked.
Yeah.
Right? Theme song here. Thank you, Kelsey. I just want to say I love now having that.
That's awesome. Don't ever
because
make that go away.
It's never going to go away.
Yeah.
I'm going to move something to the main board.
They've got so many freaking calls that are just like that.
Exactly. So that will be there forever.
I want you to know that I'm bad in bad scenarios in lab. That the song plays through my head.
Mm-hmm.
So recently, I did a cardiac arrest, and it was after we had recorded the last episode, and I went in and I look around and I'm thinking, okay, it was a middle-aged person. So I was like, okay, maybe they're not too humongous. And then I walk in and they're like 600 pounds. And I'm just like, and after I started crying, I sat there and that song popped in my head and I was like, we're completely fucked. And I was like, whatever, let's just run this as best as we can.
It almost just puts a little pep in your step because it's
Seriously.
so happily telling you.
It is brilliant.
It's like we don't need the Lucas, we need the pile driver.
I mean, ew.
It might work. Can't make him any more dead.
Goo.
Just a little gooey.
So the medic sees this rhythm change and tells the EMT right away, push her back into the ambulance.
Really?
Yes. And they take the pads that they already have waiting, put them on her, pulses are checked, no peripheral pulses are found. Her eyes are closed and she's unresponsive. So at this point, the paramedic goes, well, VTAC, I'm shocking the shit out of this. So I
don't know if I would have pushed it back in if I would have just jumped out and freaking slapped the pads on and did it right there. But
I mean, you could have.
Push it back in.
Right?
Yeah, why not?
Work inside your office.
Yeah.
I could see it.
Yeah.
Right? So first, she is charged up to 200 joules and defibrillated.
Yeah.
VTAC continues. Joules are then increased to 300, and she's defibrillated again. This time, yeah, yep. This time, the rhythm actually converts to a sinus Brady in the 50s.
Oh.
So
Start pacing, start walking.
not the greatest, but it's not VTAC, it's not VFib,
That's true.
and she ain't dead, right? So at this point, because she's still unresponsive, a non-rebreather, which I completely disagree with, BVM should have been done at this point to walk her inside. You have enough people. But they choose non-rebreather, 15 liters, throw it on her face, and then move from the ambulance to the hospital.
I would probably assume that they did that because the NRB that they were using before is probably still sitting right there.
Yes, exactly.
And they would have to go back in, pull out the cabinets, open up, get the BVM and all that, and then hook it up.
Right.
Whereas here they just do a quick
I actually
change.
did inquire as to why they did that, because I was like, ooh, I don't agree with that. And it was exactly that.
Just
it
get
was,
the fuck in there.
We just want to get in at this point because she's going to code again. Let's just throw this and go.
Right.
It was, let's just
Make
move
it
and
not our
buggy.
problem this time.
Well,
Exactly. Right. It was
We're 3 feet from getting our fucking asses out of here.
Exactly.
Let's do this.
Exactly. So they move her inside, and once inside, the crew begins to move through the ER toward the elevators to go upstairs directly to the cath lab.
Right.
Because, they had already informed 20 minutes ago that they were coming in with this STEMI. And as they're walking through the ER, they're asked by the charge nurse if this is the possible STEMI.
I was just going to say real quick, just not so I don't sound like a fucking ghoul or something, but
You are a ghoul.
well thank you. But no, I mean, get the patient in the fucking hospital because that's where they need to be.
Mm-hmm.
They don't need me to wait, another 30 seconds to a minute to get the fucking BVM and get all that shit hooked up and going. Just go.
Yep. And like I said, you're right outside.
Yeah.
So, is she getting passive oxygenation? Sure.
Yeah.
Is she getting proper ventilation? No. So as they're walking through the ER towards these elevators, a charge nurse walks up and goes, "Hey, is this the possible STEMI?" And the medic looks directly at the nurse and goes, No, it's not possible. It's a fucking confirmed STEMI. Also, we just defibrillated her in the ambulance because she went into VTAC.
Right.
And
it's not indigestion.
Right. This isn't anxiety. This is bad shit, right? Bad juju. So the nurse then tells the EMS crew, well, why don't you just come into the ER instead of going to the cath lab? And they're kind of just
Sorry, what?
Exactly. They're just kind of like,
why don't you go back to nursing school and stop talking to me?
So, right? Right. Exactly. So they turn into the ER and place her inside of a room. They give the report to the doctor that shows up, and they give a further report to this charge nurse that's telling them to go in the wrong place.
Right.
And then as they're moving her over, she codes again. Another rhythm change. And
didn't see that coming.
Exactly. Right. And this time it's the ER staff's problem because she's on their bed.
That's it.
Fuck off, Cotton. See you later. Goodbye.
Like a stewardess of old. Bye.
Yeah, exactly.
Bye-bye.
So
bye.
Yeah. So she's actually shocked again. And the rhythm converts on the first shock. So eventually EMS crew leaves and she's taken up to the cath lab. Thank God. Finally, I don't know why they had to divert, but again, we don't know why. She's taken up to the cath lab. She's done, all of her treatments in the cath lab. I don't honestly know how many caths she had or where they placed them because the crew didn't know, but she was actually released under her own power 1 7-day week period later.
Wow.
So, I mean,
as
opposed
to the 6-day week.
Exactly.
Right.
I mean,
I was a little confused by that too.
1 7-day week.
1 7-day week.
All right.
Leave me alone. It's late.
Right.
You're a night person.
Yeah, not when I'm talking.
You're a I never sleep person.
That's also accurate.
Fuck.
It was
Wake up
funny.
in the morning, it's like, timestamp 03 something. What the fuck is he doing?
Working.
Vampire. Damn.
I was working. So how do you guys think this went overall?
I mean,
Honestly, could have been worse.
It totally could have been worse, for sure.
I think aside from the comms issue, I mean, there wasn't really a lot I would do differently. I mean, yeah, they got the 10 of morphine on board.
And we'll talk about morphine and versus fentanyl here in a second.
But, yeah, I mean, it's literally aspirin, nitro, O2, and morphine.
And go.
And go.
Yeah.
Get there.
They did their due diligence in getting the 12 leads and getting the cardiac rhythms and trying to get it to the hospital.
Right.
They knew what they were looking at. So, kudos to them.
Yeah.
And I think, a lot of good decisions were made. I probably would have done the shocking inside the truck as well.
Okay.
I don't think.
I feel like I definitely would have been the idiot to shock him standing outside of my truck.
I would have done that.
But even still, I think that's acceptable.
Yeah.
I don't think that even as long as you're doing it outside and you're not going, oh, we're just gonna walk in. Hey, they're in VTAC.
Oh, no. I definitely would have scarred some random kid that was just walking to the ER because I shocked this girl standing outside the ambulance.
Oh, that would have been fun.
You just look the kid dead in the eye. You stick out your tongue and shock her. Nah.
I definitely would have traumatized somebody.
Stay in school.
Jesus fuck. Yuck. But yeah, ultimately, I think overall they did very well. I don't think they missed a lot of steps, and the steps that they did miss, I don't think were so critical that they caused the VTAC or anything like that. So, just a couple notes. As I said, we're going to talk a lot about EKGs and 12 leads specifically between today's ending of the episode and next episode.
With the Mahaa Butch.
With the Mahaa Butch. And I am so excited. God, Jesus, woman.
I honestly feel like there's no answer to this, but did they find clots anywhere else?
I don't know. I didn't even ask that. I didn't even think to ask that. Hey,
I just wanted to know.
Hey, Kelsey, do you remember when we were having a conversation about a certain paramedic level drug? And I said there are things that you think about that are high rebel, way, way up in like the echelon of where Kelly and her brain live.
I was just thinking I was just thinking more along the lines of 27-year-old female having a STEMI. What is the chances in 2 months she's showing back up, 911 calling with a stroke? That's all I was thinking. I was thinking more future issues I was going to have to respond to.
I mean,
as long as I'm not working that day, I'm happy with what we did.
And let's put it this way. Kelsey's on to something, but is that something that you're going to know? No. Is it something that you hope to keep in the back of your mind? Like, oh, hey, she had a STEMI 2 months ago.
And if it is on the day that I'm working and I go there and I see her and I know what everything just went down, get to the chopper! That's probably where we're going with that. Because I mean, that's something where you're familiar with the patient and their most recent history. Is bad. I mean, that's like, okay, we just know she had stents put in and now she's got all this fucking shit going on.
Right.
That looks like, I'm thinking clots.
Yep.
Yeah.
So.
But I mean, for them to actually, give us any feedback, good luck.
Right.
We're all counting on you.
So, the first thing I want to dive into really quick is.
Real quick though. And Emily, wait a minute. I got something to say.
You always have go.
Oh.
The floor is yours.
Thank you. I forgot what I was going to say. No, I'm just kidding.
That was so aggressive.
Thank you. Well, because I would be remiss if
that was a big word.
If I didn't. Oh no, here comes the bigger word. If I didn't assuage Emily.
Did you say that wrong? Because I don't even know what you just said.
Yes. Her proclivity for blood glucose.
Oh.
Because I would have taken a BG.
Yeah?
Somewhere along the way, I would have snuck one in.
They didn't.
Yeah, no BG. Wow.
You suck, you jackass.
That's it.
Just
the whole
for
thing
Emily.
Suck. The whole thing.
Yep.
Yep.
I mean, they could have fixed her. It probably was like 7.
BG. Yep. Done.
Yep.
Have some D10. Go home.
Yep. Done.
Sign here.
Wouldn't she have to be
Sign here. Press sign.
hyperglycemic, not hypoglycemic, to be having these issues?
Okay, so now I'm going to explain to you what a joke is.
I'm just saying her BG could have been 7 if you're gonna blame the blood sugar.
See, a joke is something people say to make those around them laugh
Well,
and
your
giggle.
joke's false. All jokes have some sort of truth behind it, and yours was just
Have
false.
I told you the joke about the jungle and Kiki yet? There's no truth to it.
Kelly, will you take over? I quit. The rest of the episode will be presented by our clinical coordinator, Kelly.
There you go.
So STEMI versus non-STEMI. That's the big thing. I think a lot of people always get not really confused, but there's no real big understanding of like an NSTEMI, right? STEMI, we know, shows ST elevations more than 1 millimeter in height. So that's one small box in 2 contiguous leads. Now, there is an exception for this rule, and that is in V2 and V3, where V2 and V3, you need 2 millimeters of elevations to actually say there is a STEMI. And a STEMI is full thickness infarct. So you are looking at full thickness through the myocardium that is actually actively infarcting. Whereas an NSTEMI will show in depression of the ST segment and is indicative of partial thickness infarct. So you're still infarcting.
Right.
It's just not all the way through.
Right.
So still bad. Not as bad as STEMI, but still bad. Right? Contiguous leads. We're going to touch base on this a lot when we talk to Butch next episode, but this is where Lisa comes in, right? Lateral, inferior, septal, anterior. Knowing, lateral, 1 AVL, V5, V6, inferior, 2, 3 AVF, septal, V1, V2, anterior, V3, V4. Those are your contiguous pairs, right? So if you have, 2 or more in those groupings, you can say there's a STEMI alert. Or a depression in 2 of those, you can say that there could be a possible NSTEMI. Going through, I did the plug for Patreon this episode because we didn't do one earlier. I just put out on the 1st of March a really great 13-minute episode that dove into the coronary arteries, where they feed, and how you can look at Lisa, look at your 12 lead, and then figure out which coronary artery is being affected, and then go into where are my symptoms coming from and what might they be. So if you're not a Patreon, go and become a Salty Veteran on Patreon. You can see that episode up there now. But lateral wall MIs. Lateral walls are fed by the left circumflex and the left anterior descending. So if one or both are blocked, you're going to get that NSTEMI, STEMI in the lateral leads. Inferior right coronary artery or the left circumflex feeds the bottom portion of that heart. Septal and anterior are both fed by the same artery, and that's the left anterior descending off of your left coronary artery. So knowing where these arteries are, again, like I said, you can kind of figure out where the signs and symptoms might be going. We had an inferior wall MI here with some lateral involvement, with, I believe, septal involvement. We had a lot of different involvement. So you're looking, at a left circumflex, maybe a separate clot in the left anterior, or it could be way up high in the left coronary artery, right? And it's not even at the left circumflex at that point in time. And in an inferior wall MI, you are going to affect ultimately the amount of ejection fraction or blood that you pump out per beat, right? And as EMS providers, we have to be cognizant that we are affecting preload with our nitrates and with our pain control medications. So this is why we always say, oh, inferior, hold off on the nitrates, or at least, like I say, do a right side 12 lead to really see if you can give those nitrates. Here, that blood pressure held like a champ the whole time. Keep giving those nitrates, right? Could a right side 12 lead have been done? Yes. Should it? Probably. You know, was it in dire need? No. You know, most of the people wouldn't do a right side 12 lead, but I think anytime an inferior wall is presenting itself, you probably should, you know, because you want to see if it's going to really be affecting your preload on that right-hand side. Or inferior walls, you might see a tachycardic rate. You might also see a bradycardic rate, right? That right coronary artery feeds that SA node. So if you have right side involvement on the inferior side, you're eventually going to affect your pacemaker of the heart, which could turn bradycardic. And now you have hypotension and bradycardia, and you're totally fucked, right? So this is, again, why we take the inferior wall so seriously, because so many bad things can happen. Lateral wall with the it fluctuates in your vital signs, especially in your blood pressure. And I think this is where you have this person. Most often you see tachycardia with hypertension, but you can see the tachycardia with hypotension.
Yep.
You know, with that lateral wall.
Which is what I had last week.
You know, and you're like, okay, like I can see the difference, you know, but you're not always going to see that bradycardia. Yeah. You know, you'll see the normal tachycardia with a low blood pressure or tachycardic and they're still high. The last thing I want to just touch base on really quick is MONA, right? Old style acronym.
That's how I was taught.
And that's how so many people were taught. Kelsey, were you taught MONA in paramedic class?
So I feel like it's backwards. We watched a video, but it was Onam.
Onam? I don't like that. MONA's better.
It wasn't. It had the same letters, but it wasn't that, because then your priorities were weird. Because it was Anum.
Anam.
Anmo.
So,
there's aspirin, nitro,
oxygen, morphine.
Yeah.
Yeah.
I mean, that's pretty much how we do it anyway. But
right, it just sounds better.
MONA's a better name.
Right.
I don't know. It's just the way the video was.
That's a stupid video.
Right.
Whatever. I mean, I mean,
if you're gonna do this kind of shit, at least have some fucking style.
Exactly.
You know,
like
Jesus.
Anam.
Right.
That's just weird.
All right, everybody. Today we're gonna learn Anam. No, today we're gonna learn MONA.
Yeah, MONA just sounds.
MONA's
it's
pretty
so
hot.
Smooth.
You know.
Not as
Maybe
hot as
it was
Lisa.
MONA. I just don't remember it being like that.
Yeah, MONA's not as hot as Lisa.
No, Lisa's definitely.
Lisa's smoking.
Lisa's smoking.
Yeah. Almost as hot as Kelly.
Damn! She's blushing, you know.
Hey, you know.
Now it's just weird.
You
know. He just.
Is this how your generation does it?
He lit.
Pretty much.
I mean, remember how I said there's that whole courting phase?
I was gonna go somewhere else. I was gonna say, remember all those like sexual harassment videos you watch? That's from my generation.
That's true. So yeah, MONA, right? Morphine, oxygen, nitrates, aspirin, Anam. I'm not even gonna go there. Morphine, oxygen, nitrates, aspirin, right? Your treatment
that sounds
for
like something you
MIs.
say before you sacrifice something to Joe Boo.
Yeah, there's
See what I did there? That's a callback.
There you go.
There we go.
So we give morphine in MIs because it decreases heart rate, it decreases blood pressure, and decreases the venous return. And it also, there's studies that show that it also stimulates local histamine mediated releases. Now, theoretically, this reduces myocardial oxygen demand. putting less strain on the infarcting heart
Right.
muscle. However, that's still theory. I haven't found enough studies to say this is 100% bona fide fact. It's still always theoretically it does this. But, I mean, how many medications do we
Right.
use that?
It's all theoretical.
It's all theoretical.
In fact, I would say probably most of them.
Now, this is something that I wanted to research morphine versus fentanyl,
Okay.
right? Because we give morphine when we are not hemodynamically unstable. We give it because it reduces strain on the heart and oxygen demand and all this other stuff. And it's always what we're taught.
Right.
Use morphine unless indicated for fentanyl.
Right.
Then I went in and I found some studies that actually show that morphine is not indicated or should not be indicated in these situations because morphine may slow the oral uptake of aspirin in an MI. And at this point, there's studies that show that, but there's not enough to say this is clinical and to stop using morphine. So still continue to use morphine, but it's something that I was finding in the literature going, this is interesting. So there's a lot of these studies that are coming out, and they're probably paid and bought for by the fentanyl people to push fentanyl and say morphine bad, you know, but...
May I interject?
Sure. No, you can't. Go ahead.
Oh. Is the reason, I'm just throwing something out there, like how they tell you not to give morphine to people who are nauseous because it could make them throw up, because if you push it too and like all the doctors in the hospital, they always give Zofran when they give morphine because it makes you nauseous because you just push it wrong. Is there a possibility that the reason that they're saying that it slows your GI system's uptake of aspirin is because if you push it too fast, you're going to cause them to vomit and then there's no more aspirin?
So this is...
Yeah.
Hold on. You are thinking the exact same way I was thinking when I was reading these papers and thinking it was a GI issue. And nothing that I said, nothing that I read, and please, if you're better at research than I am, send me these things and I will fix my statements. But nothing that I found says GI absorption. It's all oral absorption. So I don't know if it's a cardiac, because, you know, yes, it's GI in the oral tract, but we're going into the capillary beds
So I mean,
via oral.
So when I instruct when I'm administering aspirin to a patient, like my instructions are chew it and swish it.
Yes.
Swish it. I get it under your tongue, get it all over your cheeks, put it around your gums, whatever you can do until you can't swish anymore, and then you're going to swallow.
Yes, I do the exact same thing. So everything use the specific verbiage of oral uptake, not GI uptake, oral. So the only thing that I can say, Kelsey, is I don't know. I don't know if it is
I'm just saying,
GI or specifically oral capillary beds.
Well, that's my thing is, I mean, if you're having them do that, you're administering it the proper way, and it's getting all that good absorption, by the time because I mean, we're giving that right off the rip, and by the time we get to the point where we're administering morphine, I mean, there should have been plenty of time for that to absorb.
Yes. Yeah.
You know?
Because aspirin's your first line.
Right. That's
your most important one.
And they go, look at me, and they go, oh, I got a heart attack. Well, here you go.
Yep. Most important one. When I say
so
EMTs
I think
are
that
lifesavers,
it's
that.
I was actually, had a great little conversation with the guy who taught me Mona. This dude was around when they were running ambulances at the Cadillacs.
Mm-hmm.
And he asked me the question. He goes, what is the only drug that you carry in your bag that is 100% proven to save a life? And I'm like, oxygen, fucking glucose. He's like, no. Aspirin. And who gives aspirin? EMTs.
EMTs. Yep. Go ahead, Kels.
So I just did a quick little research. Morphine decreases morphine decreases the absorption of some blood thinners like Plavix.
Okay. That's interesting.
So I think it's more
of a blood thinner deal than a...
if it acts on the P2Y12 morphine will affect it, but aspirin works on something with an X. Aspirin works on your COX1s and your COX2s.
Right.
So morphine can actually decrease your absorption of some, like a Plavix, which acts on your platelet inhibitors themselves, but not necessarily morphine.
Or aspirin.
Or aspirin,
Aspirin.
sorry.
Yeah, I got
Right,
you.
because
Many
they're
drugs
two,
running
they're
through
two
my brain
different
at once.
enzymes.
Two completely different
Right.
things, yeah. Okay,
Interesting.
that's cool.
The more you know.
And
So-
now you know
Yes.
enough.
And now you know enough. Thank you, Kelsey. So,
Sorry, that was really confusing to everybody at home, but if you just look up, does morphine decrease aspirin absorption, the first article that's on there and a bunch after basically says that it has no significant effect on aspirin, but it does with P2Y12 inhibitors.
interesting.
Chemistry.
Way more than I can mouth vomit out right now.
We don't need you to. So
Chemistry.
with that, we're going to end it for today. Join us definitely for the Patreon. It's going to be an exciting, really interesting episode on the 23rd. But if you're not a Patreon subscriber and you want to have more EKG aficionado science, we're going to be talking with our friend Butch next free podcast on April 1st. And he is going to give us a slew. Like, I had to cut him down.
Oh, I know.
Like, he was just like, I'm going to talk about
told
this
you.
and this and this and this. And I'm like, dude, we have an hour. Like, I'll bring you back. We can have you back
told
as
you.
many times as you want. So the
Mahaa
EKG,
Butch.
the EKG conversation that we're going to have is going to be fan-fucking-tabulous next episode. So please join us for that.
We're
Till
gonna
next
we're
time,
gonna have to
everyone.
have some kind of like the great one music, you know.
I'll find something.
Yeah, we have to have something.
I will totally find something. Does he know wrestling? Can I pull a wrestling reference, or does it have to be movie?
It might be, but mostly movie though. He's more of a movie
Okay,
dude,
I will find a movie reference because I can't be like, I can't pull a rock reference and be like, you went 1-on-1 with the great one, and and him getting it.
Yeah, true.
I'm sure I just made everybody that is a rock fan do that with me. You're welcome. So till next time.
Raise an eyebrow.
And raise an eyebrow. Till next time, everyone, stay safe and
Donuts.
Thank you for listening to today's episode. If you'd like more information on the podcast or to send us a call to review, visit medicmaterials.com/podcast. To learn more information, like us on Facebook at Medic Materials EDU, or watch our weekly instructional videos on the Medic Materials YouTube channel.